Hello everyone, this is Dr. Singaram, your pediatrics faculty. In today's session, I am going to discuss about the recall questions in pediatrics asked in this INI-CET May 2025 exam. Before I start the session, this is my overview about the questions in pediatrics in this particular exam. This was a typical INI-CET paper where some questions were from the expected topics like PYQs and PYTs. There were some new questions and there were also some older questions which have been again asked, like for example marasmus, which was not asked for some time. It again appeared in this particular exam. So this particular paper in pediatrics had all sort of questions which can be expected in an exam, starting from easy question to even tough questions also, and there were some new questions as well. So with that, let us get started with the discussion of the questions. I have tried to recollect the questions and the options which have been given by the students who have actually attended the exams, and if there are any modifications in the questions as well as option, please feel free to share in the comment section below. Let us get started with the first question. The first question is: a mother brings a child born at home without any complications at the time of birth, and also the baby shows cyanosis on crying. There was a noticeable systolic murmur. The doctor diagnosed the case as tetralogy of fallot. Which of the following is seen in this condition? Left ventricular hypertrophy, pulmonary infundibular stenosis, interatrial septal defect, and transposition of great vessels. It is a fairly straightforward question. The question is asking about which of the following is a component of tetralogy of fallot. We all know that it has got four components. Number one is overriding of aorta. Number two is the pulmonary stenosis, which we refer to, but it's actually the infundibular pulmonary stenosis, which is the correct version. And third is VSD, ventricular septal defect, and fourth is right ventricular hypertrophy. So going by that discussion, it is very, very clear that the answer for this question is option B, which is pulmonary infundibular stenosis. Because the option A, we don't get left ventricular hypertrophy, instead we get right ventricular hypertrophy. There is no interatrial septal defect, it's rather ventricular septal defect. And transposition of great vessels is no way associated with tetralogy of fallot. And if you can recollect, the systolic murmur here in this condition is due to this pulmonary infundibular stenosis. So the clear answer is option B for this particular question. Moving on to the next question. A neonate is presenting with jaundice due to breastfeeding. This can be due to fatty acid inhibition of which of the following mechanisms? Is it intracellular binding of protein, hepatic uptake of bilirubin, conjugation of bilirubin, or excretion of conjugated bilirubin? See, this is a question related to the topic of breast milk jaundice, which was also asked in the last year's INI-CET exam. But in that particular exam, they asked about a different aspect of breast milk jaundice regarding statements about breast milk jaundice, and one more mechanism of breast milk jaundice was asked. In this particular exam, a different mechanism has been asked. So let us first review the topic and then we will arrive at the final answer. First question to be answered is it an early onset jaundice or a late onset jaundice in the baby? It is definitely a late onset jaundice, usually presenting beyond 3 to 4 weeks after birth. So it is not going to be an early presentation. That is number one. Number two, the reasons are not clearly understood, but these are the proposed theories. It is said that breast milk contains some substances which can predispose to jaundice. Number one substance which is included is high free fatty acid concentration, and this free fatty acid concentration is supposed to cause inhibition of conjugation of bilirubin. It is supposed to cause inhibition of conjugation of bilirubin, thereby resulting in increased unconjugated bilirubin level. Number two theory which has been proposed is presence of beta glucuronidase activity. This beta glucuronidase activity causes deconjugation of bilirubin. What is the meaning of deconjugation? It converts the conjugated bilirubin back into unconjugated bilirubin. That is what is meaning of deconjugated. In both these situations, there is going to be increase in unconjugated bilirubin, thereby resulting in jaundice. This is what is the proposed theories why jaundice occurs in breast milk jaundice. But all said, breast milk jaundice is always a benign condition. Please understand that. So that is why you will never interrupt breastfeeding in this particular condition. That is what is clearly given in the text, that interruption of breastfeeding is seldom required. So going by all this discussion, if it is fatty acid, it will cause inhibition of conjugation of bilirubin. That will be the answer for this question. So for the upcoming exams also, please study this topic of breast milk jaundice properly, because any variations of this question is possible in the future exams. Now, moving on to the next question. Which of the following describes the metabolic state of marasmus? This is a well-known topic by most of the students, even though the topic did not come in the recent exams. It was repeated asked in this particular exam, right? So always remember, when a topic is important or it's a basic topic in pediatrics, always learn it. Don't skip that topic because it was not asked in the recent exam, right? Marasmus, Kwashiorkor, these are all standard topics in pediatrics which should always be remembered for any exam. Okay, so let us see this particular question. Which of the following describes the metabolic state of marasmus? Edema due to severe protein deficiency, severe calorie deficit with normal serum protein, increased insulin levels with reduced lipolysis, positive nitrogen balance, and low cortisol level. This is a pretty straightforward question. Marasmus is a condition of severe calorie deficit with normal serum protein. If you look at the option A, edema due to severe protein deficiency is seen in Kwashiorkor. Correct? It is seen in Kwashiorkor. So anyway, we have already arrived at the answer, but just to eliminate the other two options also, we'll just have a look at it. The third option says increased insulin level and reduced lipolysis. This is wrong, because in marasmus, due to the state of chronic starvation and low glucose availability, the insulin level actually decreases. And also the lipolysis will not be reduced, instead it will be increased, because the bodies try to mobilize the available stores into energy for the functioning, right? So that is why there will be increased lipolysis in this condition, exactly opposite of what is given in the option C. The last option which is given is positive nitrogen balance and low cortisol level. That is also wrong, because in the state of marasmus, there is a breakdown of the muscle proteins, okay, leading to the generation of energy. And when this protein breakdown is happening, the nitrogen which is released gets excreted in the urine. So there is not a positive nitrogen balance, but instead there is a negative nitrogen balance. And also, due to chronic stress and chronic starvation, the cortisol level will not be low, it will be increased cortisol level. So you can see in marasmus, what happens is exactly opposite of what is given in the options C and D. So the clear answer for this question without any doubt is option B only, because marasmus is predominantly calorie deficit with normal serum protein. That is this particular question. Option B is the answer. Moving on to the next question. A 9-month-old child is unable to sit with support but can roll over from side to side. Child can say words like mama and dada and exhibits stranger anxiety, becoming distressed upon encountering unfamiliar people. What is the appropriate next step in the management? Will you just reassure because it's a normal developmental variant, or will you immediately refer for the assessment of development in this child, or will you perform cranial MRI, that means MRI brain, or will you start physical therapy to help the child to sit? Okay, let us analyze. This is a question related to development. Now, if you see what all things the child is able to do, rollover is attained by 4 months of age. That is very well possible for a 9-month-old child, so that is okay. Child can say words like mama and dada, that is bisyllable. That is also attained by 9 months of age, which is normal for the child, bisyllables. Stranger anxiety, that is attained by 6 months of age itself. Okay, now our concern in this question is what is given in the first line. What is that? Unable to sit without support. Tell me, what is a normal time at which sitting without support is attained? Sitting without support is usually attained by 8 months of age. 8 months of age. But it is given in the question, the child is already 9 months of age, and we just have to comment whether it is a cause of concern in this child. Remember, 8 months is what we usually read and remember, but there is always something like an extra time which we can give for that milestone to attain. And when will you call it as delay? Delay if it is not attained by 10 months of age. Very, very important. You will call it as a delay for this milestone only if it is not attained by 10 months of age. The child is only 9 months, so probably we'll have to wait 1 more month, and by that time child could have attained sitting without support. They're able to follow this, right? So now tell me, is it actually a developmental delay in this particular child? Not at all. So what will I do? I will just reassure the parents saying that it is normal only. Maybe we'll wait 1 more month. Your child will attain that particular milestone. So the correct answer for this question should be option A, that is reassurance, because it's only a normal developmental variant. Have a look at this text from OPGI textbook where they say the upper limit for attainment of milestone. That means by that age, if it is not attained, we can call it as delay. First, vocalization by 6 months not attained, we can call it as delay. Sitting with support, that is what I was explaining, we can wait up to 10 months. Standing with assistance by 12 months. Okay, these are all upper limit. After that also that milestone is not attained, we can call it as delay. So the clear answer for this question is it is only reassurance because it's only a normal developmental variant. Moving on to the next question. A 4-day-old neonate is being breastfed by her mother. Consider the following and you have to tell which of the following shows proper attachment. Signs of proper attachment. It's also called by this name, latching. Okay. Now, first let us look at the picture itself. This is the correct way of describing the correct attachment or latching at the time of breastfeeding. Can you see some important points in that picture? Number one, the mouth of the baby should be wide open, and at the time of feeding, when there is enough amount of milk in the mouth and the cheeks will be full. Okay, so that is very clear. Second thing, look at this area, the chin. The chin of the baby is touching the mother's breast. That is easily understandable. Third important is to look at the lip region, the upper lips and the lower lips. What is happening? It is coming out like this. What is the meaning of coming out? The lips should be everted. Okay, the lips should be everted at the time of feeding. Okay, coming out means everted. Then the last one, look at this. Not only the nipple, the areola also should be inside the baby's mouth, and if at all visible, this part of the areola can be visible. What is that? Upper part of the areola may be visible, but lower areola should always be inside the baby's mouth. These are all the signs of good attachment or latching. So if I take you back to that question, cheeks and mouth are full, it's a sign of good attachment. That is correct. Lower areola more visible than the upper areola. That is wrong. It is upper areola more visible than the lower is possible, not the other way. So that is wrong. Chin touches the mother's breast. That is also correct statement. Lower lip is inverted. That is wrong. The lips always should be everted. So these two are wrong statements. So what are the correct statement? A and C are the correct statement. So option B will be the answer for this particular question. Moving on to the next question. A neonate is born at 36 weeks of gestation, presenting with respiratory distress and requires to be on 30% FiO2 to maintain the SpO2. The baby is otherwise normal. The chest X-ray is given. What is the diagnosis? If you look at the options, transient tachypnea of newborn, respiratory distress syndrome, meconium aspiration syndrome, pneumonia, all are causes of respiratory distress in a baby, in a neonate, right? Then how will you decide your answer? The clue is going to come from the X-ray. Now this is the same X-ray which I put it up in a magnified view. All you can see is lot of white markings seen on both lung fields. Can you see that? All these areas or these white markings like that, you're able to notice, right? Multiple white markings like that, you're able to notice on both sides of the lung field, especially starting from the perihilar region. Can you see that? There's a perihilar region and all the white markings are seeming to go outside from that perihilar region only, right? And all this perihilar region markings represents fluid in the lungs, presence of fluid in the lungs. And which of those four options is characterized by the presence of fluid inside the lungs? It is nothing but transient tachypnea of newborn. This is what we study as a condition of, it's a benign condition characterized by delayed clearance of lung fluid resulting in fluid inside the lung, and that fluid is the one which appears as white markings in the lung fields. Okay. Now this appearance is like that of a sun with the rays going outside. So this is also called sunburst appearance. A very typical finding of transient tachypnea of newborn. Now, when I discuss this question, some of you may be having some doubt regarding the answer because look at the gestational age of the baby. It is written as born at 36 weeks of gestation. And you may think it's a preterm baby. And you may also consider what possibility? Respiratory distress syndrome. But think about this. Respiratory distress syndrome is usually encountered in babies born before or equal to 34 weeks of gestation. Please understand this point. Not at 36 weeks of gestation, it is very unlikely. Second thing, in respiratory distress syndrome, what will be the characteristic X-ray finding? Full white out appearance of the lung. Very important. It is not just streaks of white lines will be present. Fully whitish out appearance of the lungs will be noted, which is not the case given in this particular X-ray. And what is the next doubt going to be? Transient tachypnea of newborn, you must have studied for term babies, right? It's a condition in term babies, that too babies born by LSCS, lower segment cesarean section. But in this question, it is given as 36 weeks of gestation. So that could cause a doubt. So for this, let us look at what Nelson textbook of pediatrics has to say. You see here the first point, the common risk factors are of course term baby delivered by cesarean section. But can you see there are other risk factors also, namely twin gestation, precipitous delivery, gestational diabetes in the mother or mother having maternal hypertension, and one more is late prematurity. What is the meaning of late prematurity? It is a baby born at 35 or 36 weeks of gestation. That is what is the meaning of late prematurity. In our question, 36 weeks is given, which can fit into the criteria for late prematurity only. There also TTNB is possible. Now look at the very next line. TTNB is transient tachypnea of newborn, is characterized by early onset of tachypnea, sometimes with retractions or grunting, but important thing is it is relieved by minimal O2 requirements of FiO2 less than 40%. If you see the question one more time, it is written, the baby requires only 30% of FiO2 to maintain the SpO2, that is also less than 40% only. So late preterm, minimal oxygen requirements, otherwise normal baby, and presence of fluid in the lungs. Without any doubt, the diagnosis is going to be transient tachypnea of newborn, which will be the final answer for this particular question. Moving on to the next question. A 6-week-old baby presents with failure to thrive and poor feeding. There is complaints of non-bilious vomiting after feeding, which started 3 weeks after birth. 6-week-old baby and the vomiting started 3 weeks after birth. Okay. The vomiting is forceful, but it is not projectile. Okay. Bowel movements are normal. Per abdominal examination has no significant findings. What is the most probable cause? Is it a cow milk protein allergy, GERD, intestinal obstruction, or pyloric stenosis? This is a question where we have to analyze the findings and try to arrive at an answer. This is a 6-week-old baby and having vomiting since 3 weeks after birth. If you look at non-bilious vomiting, the complaint given in the question, which option is very unlikely? Intestinal obstruction is very unlikely because usually there will be bilious vomiting. Okay, there will be usually bilious vomiting. Of course, there can be non-bilious vomiting also, but most likely it is bilious vomiting. That is number one. Number two, if it is intestinal obstruction, the bowel movements are not normal. The bowel movements are actually decreased or absent. Very important. Bowel movements would be decreased or absent. And not only that, perabdominal examination will not be normal. There would be abdominal distension also noted. There will be abdominal distension would be noted. So all these things are not given in the question. So straightforward we can rule out intestinal obstruction. Then cow milk protein allergy is something like a very early diagnosis at this age of 6 weeks. Number one. Number two, cow milk allergy should have other supporting evidences also. For example, presence of blood in the stools is an expected finding in many cases, but that is not given in this particular question. The second thing is that the child will be excessively irritable. And there can be other evidence of allergy in the child also in the form of eczema, which is not given in the question, or there can be a parent history or a family history. We'll put it like this, family history of other allergic diseases or atopy could be present. Is any of this given in the question? Not at all. So we can rule out cow milk protein allergy also in this. Then we are left with two more options, GERD and pyloric stenosis. Pyloric stenosis resembles the presentation in many ways. What is that? Late onset of vomiting, like 3 weeks after birth. It is given like that. Non-bilious vomiting, again in pyloric stenosis you will get it. And also forceful vomiting. Okay, even though we say projectile, but forceful is also good enough description for vomiting in pyloric stenosis. But What tells you it is not pyloric stenosis? Very, very clearly written, per abdomen, there is no significant findings. If it is pyloric stenosis, what should be noted? If it is pyloric stenosis, there should be an abdominal mass. Which area I am talking about abdominal mass? Epigastric mass. Okay, right? It is epigastric mass which will be present. Don't forget this point, epigastric mass. What is the shape of the mass? Olive shaped mass should be noted. Is it given like that in the question? Not at all. So that is ruled out. So the final answer for this question is going to be GERT. Okay, gastroesophageal reflux disease. So think about this. If you have a presentation which looks like pyloric stenosis, but no per abdomen finding, like no mass is noted, no visible peristalsis is noted, then you think about the possibility of GERD. So that will be the answer for this particular question. Option B, gastroesophageal reflux disease. Okay. Then moving on to the next question. This is a new question which has not been asked many times in the past, and this is relatively a new topic also. So I will provide little bit more information about this topic also. A 4-year-old female with SLE presents with proteinuria and rising creatinine values. Renal biopsy shows the typical wire loop lesion. What is the most appropriate induction therapy? Rituximab, IV cyclophosphamide with steroid, mycophenolate mofetil only, high dose steroid only. First of all, you should understand this is a SLE with proteinuria, meaning it is lupus nephritis. It is lupus nephritis. I'm sure you read about the different types of lupus nephritis, right? So many types or class like that we say. And viral lesion is typically seen in class 4 lupus nephritis, which is actually a severe form of lupus nephritis. Please understand this point, okay? Severe form of lupus nephritis. And when we talk about the management of severe lupus nephritis, please understand in most of the lupus nephritis, we give corticosteroid therapy. But very important is corticosteroid therapy alone is not sufficient to induce a remission in severe forms of lupus nephritis. For example, class 4 is a severe form. There, corticosteroid alone will not be sufficient. So what else should be started? So before going to that, you should know that there are 2 phases of treatment in lupus nephritis. One is called induction phase, other one is called maintenance phase. In induction phase, what we do is monthly intravenous cyclophosphamide. Intravenous cyclophosphamide should be given. And that too, 6 consecutive monthly intravenous cyclophosphamide should be given along with steroids. Very important, along with the steroids. This is for induction. Maintenance. Okay, once the induction phase is over, we go for the maintenance. There are 2 options available. One is cyclophosphamide. Another one is mycophenolate. A Nelson textbook very clearly mentions, with the presently available evidence, mycophenolate is a better choice for maintenance compared to cyclophosphamide. Now let's get back to the question. The question is saying, what is the most appropriate induction therapy? What is going to be the answer? It is IV cyclophosphamide with steroid should be the induction therapy. If you look at the other option, mycophenolate mofetil is for not induction, it is for maintenance. Next, high dose steroid alone will not be sufficient, right? Because I already told you it should be steroid with cyclophosphamide. Rituximab is like an alternative. That means if the child is not responding only to cyclophosphamide and steroids, then we may consider rituximab. But that is not the first line induction therapy, right? So very, very clear answer for this question is IV cyclophosphamide with steroids for this severe form of lupus nephritis. Moving on to the next one. Which vaccine is contraindicated in a child with SCID? What does SCID stand for? Severe combined immunodeficiency. We know that it's one of the most severe forms of primary immunodeficiency, characterized by immunodeficiency in both T cells and B cell. And always remember, in combined immunodeficiencies or severe immunodeficiencies, live vaccines are contraindicated. Live vaccines are contraindicated, and you should be knowing the reason. It is simply because in a severely immunodeficient child, if you give the live vaccine, the vaccine strain itself will undergo uncontrolled proliferation. and it can even result in serious problems like pneumonia, meningitis, like that, right? So it is due to uncontrolled proliferation of the vaccine strain itself in the immunocompromised child, which can be very life-threatening for that particular child also. So that is why live vaccines are contraindicated in SCID. And out of the 4 options, which is a live vaccine, it is clearly MMR vaccine that is contraindicated in this particular child. That will be the answer for the question. If you look at hepatitis B vaccine and inactivated polio vaccine, they're all killed vaccine, okay, which can be given safely for this child. DTAP is also subunit vaccine, which can also be given safely for this particular child. So all these things are not contraindicated, but MMR is a live vaccine, which is definitely contraindicated in this particular child. And please understand one more thing, even though we can give killed vaccines, okay, safely in this child, it is found out that the immune response or the response to the vaccine may not be occurring properly because of severe immunodeficiency. Okay, so killed vaccines can be given, but it may not be fully effective in a child with a SCID. But coming to the point for the question, live vaccines are always contraindicated. Moving on to the next question. A 2-year-old child presents with a leg pain, difficulty in walking, and easy fatigability. What is the unusual diagnosis for this child? It's quite a surprising question where you have to analyze the individual options and tell the answer. Ewing sarcoma, metastatic renal clear cell sarcoma, metastatic neuroblastoma, and metastatic retinoblastoma. I hope that this was the actual question which came in the exam, and I will try to do the analysis of the individual options and try to come to the final answer. If there are any modifications, please let me know in the comment section below. Okay, right. Yes, leg pain, difficulty walking, something related to the limbs or the limb bones. Easy fatigability could be due to a part of anemia present in this child. Now, if you look at the first option, Ewing sarcoma, is it a possible diagnosis for this child? Definitely yes. Ewing sarcoma is one of the primary bone tumors. Even though we study the classical age group for Ewing sarcoma is in the 2nd decade, it can very well be possible in a young child also, and typically it will present with bony problems like pain and difficulty in walking and can be associated with anemia also. So that is possible diagnosis and cannot be the answer for the question. Little below, neuroblastoma. We all know that neuroblastoma is the common extracranial solid tumor in children, and neuroblastoma is prone for metastasis to the bone and the bone marrow only. And this presentation, like anemia and bone pain with difficulty in walking, is very well possible with metastatic neuroblastoma. In fact, this is one of the typical presentations of neuroblastoma also whenever it has metastasized. So that is also possible. So now our confusion is between the remaining 2 options, metastatic retinoblastoma and one more is metastatic renal cell carcinoma. Let us clear these 2 options with the help of Nelson's text. In Nelson, it is clearly mentioned a bone scan is performed if the histological diagnosis confirms clear cell sarcoma of the kidney or rhabdoid tumor of the kidney to look for bone metastasis. That means as soon as you make a diagnosis of clear cell sarcoma of the kidney, you have to do a bone scan. That means there is relatively higher chance of bone metastasis in clear cell sarcoma of the kidney. Okay, so that option is there. Look at the next one. That is something related to metastatic retinoblastoma. Let us see what Nelson has to say. Retinoblastoma can have hematogenous or lymphatic spread to distant site, including bone marrow and lungs. So here also they are saying bone marrow spread is possible and bone involvement is possible. Then what will be the answer? Let's look at little further what Nelson textbook says regarding retinoblastoma. It says that metastatic disease is rarely present in retinoblastoma. Can you see this word? It is rarely present in retinoblastoma. An evaluation of cerebrospinal fluid and the bone marrow for tumor metastasis and bone scan, that is a radionuclide scan, are only required if indicated by clinical, lab or imaging finding. That means routinely you should not search for bone metastasis by doing a bone scan in case of retinoblastoma, whereas in the previous slide we have seen very clearly that once the diagnosis of clear cell sarcoma is made itself, you have to perform bone scan. So going by this statements from Nelson textbook of pediatrics, we can say that metastatic renal clear cell sarcoma can have bony presentation more likely compared to metastatic retinoblastoma. So, question is asking which can be an unusual diagnosis. My answer for this question is going to be metastatic retinoblastoma. So, clearly repeating one more time, both option B and D are possible answers, but Nelson textbooks clearly say that involvement of bone is more common with metastatic renal clear cell sarcoma compared to metastatic retinoblastoma. So that is why I am choosing option D as the answer for this question. Moving on to the final question. A 4-year-old child is presenting with difficulty in walking, a broad-based gait, and inability to perform heel-to-toe walking. Child was clingy towards his mother. That means he is very anxious. That is why he is clingy towards his mother. On examination, the child is hyperreflexive and Babinski sign is positive. What could be the probable diagnosis? Is it Guillain-Barré syndrome, cerebral palsy, ADAM, what is that? Acute disseminated encephalomyelitis, or is it a spinal cord lesion? This is purely an analytical question. Okay. Let's look at the options one after another. Spinal cord lesion, right? Look at the last option. Can it be spinal cord lesion? Spinal cord lesion is very unlikely because in spinal cord lesions, you may not always get hyper reflexive. That means what? Deep tendon reflexes are not always hyper reflexive. And Babinski sign is always not positive, right? So that is something not telling you that it is that is something which is not suggestive of a spinal cord lesion. If it is spinal cord lesion, there should be additional clues given in the form of sensory deficit should be given, correct? The sensory deficit should be given, which is not given in the question. Or they should also have given something like bowel or bladder involvement. Bowel or bladder involvement. So none of this is given in the question, so it is very unlikely to be a spinal cord lesion. That is out. Can it be acute disseminated encephalomyelitis? In acute disseminated encephalomyelitis, the name itself suggests encephalomyelitis means some evidence of encephalopathy or encephalitis should be present in the form of mental status changes should be given. Mental status changes should be given. And not only that, history of seizures or presence of seizures should also be given. Is it given like that in the question? No. And also, there is no acute triggers to say that it is only an acute presentation in this child. The question looks like it is a long-term problem in that child. Okay, right? So again, acute disseminated encephalomyelitis is not possible for this question. Look at the first option, Guillain-Barré syndrome. Guillain-Barré syndrome, we all know that it's one of the important causes of AFP. What is that? Acute flaccid paralysis. Very important. Acute flaccid paralysis. Acute doesn't look like the presentation given in the question. And one more thing, in Guillain-Barré syndrome, there will be areflexia. Correct? There will be areflexia, whereas in the question it is given hyperreflexia. So that itself will rule out this option. Number 2, in Guillain-Barré syndrome, you will have ascending paralysis. Starting from the lower foot area and then ascending up, ascending paralysis. Is it given like that in the question? No. For that reason also, we can rule out Guillain-Barré syndrome. So what is the answer for the question? It is cerebral palsy only. And think about this, cerebral palsy typically presents with UMN type of weakness. And we have got clear evidence of UMN weakness in the form of hyperreflexia. Hyperreflexive, that means dependent reflex is hyperreflexive, and Babinski sign is positive. Very, very clear. Even the inability to perform heel-to-toe walking as well as broad-based gait are all manifestations of spasticity in the lower limbs. Okay. And this could very well be possible that it was a case of what type of cerebral palsy? Probably spastic diplegia type of cerebral palsy, where both lower limbs are having increased tone or spasticity. So the clear answer for this question by ruling out the other options is cerebral palsy. I hope you are able to follow the discussion of the pediatric question asked in this INI-CET May 2025 exam. And with that, I conclude the session and wish you all the best. Thank you.